Clavicle shaft fracture. Clavicle is a S-shaped bone. Medially there is sternoclavicular, laterally AC joint and ligaments, convener and trapezius part of the coracoid ligaments. Medially there is sternomastoid muscle attached and laterally trapezius, pectoralis major and deltoid. Mechanism of injury, mainly from fall from height, motor vehicle accidents, sports injury, direct blow to shoulder, or rarely a direct injury by stick or something. Medial fragment is pulled superiorly and anteriorly by pull of the sternocleidomastoid muscle, and distal fragment is pulled inferiorly by weight of the arm and deltoid. Careful evaluation of the deformity. Neurovascular examination is must. Chest auscultation, air entry is part of examination and must be documented. Radiographic evaluation, we have various views, mainly AP view, true AP view with 15 to 30 degrees cephalic tilt, and for better assessment, 45 degrees cephalic caudal tilt known as Kisana view. Normally AP view and AP view with 15 to 30 degree of cephalic tilt is good enough. Now middle third of the clavicle, they comprise mainly 80% of the fractures of the clavicle, and they have simple fracture, wedge fracture or complex fracture. Treatment option for clavicular fracture depends on displacement, deformity, comminution and neurovascular status. We will be talking about surgical management. Indication for surgical treatment: open fracture, associated neurovascular injuries, displacement and shortening more than 2 cm, comminuted fracture, segmental fracture, skin tenting or impending open, polytrauma, floating shoulder, bilateral clavicle fracture, cosmetic deformity or earlier return to function. Contraindication of any of the surgical treatment would be infection in the area, irradiation, burns of the clavicle area, unfit patient, patient having poor compliance, or maybe elderly patient having sedentary lifestyle. Plating could be either anterior inferior or anterior superior. Now anterior inferior plating has the advantage of easy screw trajectory, longer screw as AP diameter of the clavicle is more than the superior inferior diameter, less incidence of neurovascular injuries, and decreased hardware prominence. But disadvantages are we are not familiar with this approach most of the time, and plate obscures the imaging during surgery and even post-op. Anterior superior plating. Anterior superior plating has a more familiar approach, can be extended medially, laterally if required, and allow better imaging. However, injury to underlying structures, vital structures, is possible by overshooting of drill bit or tap, but this can very well be avoided by using a drill bit in a chuck and only exposing 18 millimeter beyond the sleeve, as typically length of the screw inserted in this area is 14 to 16 millimeter in female and 16 to 18 millimeter in males. Approaches superior, supine or in B chair, an oblique anterior approach or superior approach depending on the surgeon's preference. Oblique 8 to 10 centimeter incision is made inferior or superior to the clavicle, centering over the fracture. Plating can be done through smaller incisions without opening at the fracture site. We dissect transversely and identify and tag the platysma, identify and secure supraclavicular nerves. incise clavipectoral fascia and expose the fracture. Hold the fragment with pointed clamps to minimize soft tissue trauma. Plate can be held to bone with sleeve, K-wire, or maybe with pointed clamps. Using a lag screw, either independently or through the plate, we proceed with fixation of 3 screws on either side of the fracture, but in a heavy patient, we must use 4 screws on either side of the fracture. Similarly, a wedge fracture can also be lagged either independently or through the plate, making sure not to enter into subclavian space and hence avoiding injury to the neurovascular structures. Every painstaking effort should be made to identify, to protect supraclavicular nerves by gentle dissection. In case there is any injury to the branches, there may be anesthesia or paresthesia along the incision. It is advisable before and after surgery to inform patient about the anesthesia, though this get recovered in 4 to 6 months time and really never matter of concern unless there is a neuroma formation which need to be excised. Though we are using anatomic plates, every effort should be made to contour the plates as per size and shape of the clavicle by different instruments. These are bending instruments, everyone knows in fact. Few cases, a 42-year-old male with left clavicle fracture treated with anatomic plate, a thin patient, a 4-hole, 8-hole reconstruction plate is used with 2 lag screws. A female patient with scapular fracture and clavicle fracture, floating shoulder, fixed with anatomical plate and a plate for the scapula. A male patient, a long anatomical plate is used, fracture healed. Now superior versus inferior plates. Superior clavicle surface being the tension side is more resistant to bending forces depending on bone-to-bone contact and the combination. As the distal fragment is bent inferiorly, fracture opens and the inferior plate is loaded in bending. So superior plate shows more rigidity to this increased torsional and axial forces. Bicortical screws construct have a better rotational stiffness than unicortical. When plating is done, they are stable, rigid construct, early mobilization possible, less non-union and malunion, but resurgery is required to removal of the implant, or maybe there is hardware related complication or problems. Now we have medullary fixation. Large threaded cannulated screws are available, flexible elastic nails, or maybe K-wire, which are associated with risk of the migration. Normally, intermedullary fixation is useful when plate fixation is contraindicated in the form of bad skin or severe osteopenia, but fixation is less secure. We have elastic nails, titanium elastic nails, typically inserted from retrograde, means from medial to lateral. They are best in fracture without combination. Small incision at fracture site may be needed for open induction. We have nails from lateral to medial, and this is screw intermedullary fixation. Medially, there is a screw which get engaged in medial cortex, hence avoiding migration of the nail, which is a common feature in nailing. Now, intermedullary nail skin incision is cosmetic, less soft tissue stripping, decreased hardware prominence, easier implant removal, but medial migration is common, lateral perforation is common, there is no axial and rotational stability. Biomechanically, plate is a better in resisting displacement. Complication when using plates as internal fixation are related to actual procedure or the hardware. Wound infection, anterior chest wall numbness, plexus symptoms, represent soft tissue complication are really related to the procedure, while mechanical failure during the course of healing or local irritation of the hardware after healing as hardware related complication and often lead to removal of the implant and may be risk of the refracture through the screw holes after removal. Early fixation is desired if indicated. There is no concept of wait and watch. Chances of tethering fracture fragment to upper trunk of the brachioplexus which need to be explored during fixation, or there may be late return of function if associated with late reconstruction 3, 4, 5 weeks. Result of clavicle fractures, surgical treatment depends on the surgeon's skill, choice of incision, choice of approaches, choice of implants depend on surgeon preference and experience. Thank you.